A very good afternoon, everyone. It is with great honor and pleasure to welcome you all to the 16th Pediatric TB Eco Clinic in collaboration with Regional Pediatric Center of Excellence for Tuberculosis. The Eco Clinic is a dynamic platform for case-based clinical discussion and dissemination of knowledge and bringing all experts together across the country for managing tuberculosis among children. On behalf of National Institute of TB and Respiratory Diseases, I extend a very warm welcome to our esteemed DDG TB Central TB Division, Dr. Urvashi B. Singh and her team. I also extend my heartfelt welcome to the directors and representatives from NIRT, NTI, state TB officers, directors of STTCs, esteemed faculty members from medical colleges, district TB officers, medical officers, pediatric TB specialists, and all healthcare professionals participating in this session today. Now, let me please introduce the faculty from NITRD. I am Dr. Dhulika Dhingra, Specialist Peds, and I will be moderating today's session. And with me is Dr. Sangeeta Sharma, Chief in charge of the National Center of Excellence for Pediatric TB, and also the former director of NITRD. To my extreme left is Dr. Alok Yadav, CMO, NFSG, and pediatrician at NITRD. I would now like to request Dr. Sangeeta Sharma ma'am to address the gathering and also welcome DDG ma'am, Professor Urvashi B. Singh. Over to you, ma'am.
Welcome, dear friends, colleagues, seniors. Welcome, DDG ma'am, Dr. Urvashi Singh and her team from the Central TB Division. And we have also the directors from NTI and the NIRT team also there. And then we have all of you that are most precious to us. So, without wasting time, now I would request our DDG, Dr. Urvashi Singh, Professor. She is, we all know she needs no introduction. She is also the professor and head of the TB Diagnostic Division at All India Institute of Medical Sciences, New Delhi. So, Dr. Urvashi, for your words of wisdom, please.
Good afternoon, Dr. Sangeeta, and good afternoon to all experts who are here today. The teams from all the centers and centers of excellence. NITRD continues this effort every month, I think, Dr. Sangeeta, and that is an immense effort. Let me compliment Dr. Sangeeta's efforts for years together, where this tradition of sharing experience continues, and I highly appreciate this effort because to my mind it is a continuing medical education effort which goes a long way in training our peripheral level district TB officers, our medical officers, our in the whole the TB program, whether it's a state level, block, district, whatever. Pediatric TB is an area where we all know that diagnosis is difficult, the sample collection is difficult, the disease presentation is different, and these poor children possibly have a poorer immune response than an adult may have. There are diagnostic delays because of these issues and sometimes a few other issues. So our effort towards taking care of children has to be very concrete, structured, and learned. We all have to know where the gaps may happen when trying to diagnose a child with TB. Unless we are aware of the gaps, where mistakes could happen or where we could miss a child with TB, we will not be able to address those challenges. Hence, the knowledge of pediatric TB is a vast subject, and only those who've actually practiced it are the best teachers in the field. So thank you everyone who's actually contributed to the field, and even those who are learning from the experiences are also their effort to learn is also complimented. But then these learnings don't have to stop with the clinic today. These have to go home to everybody to enhance the effort that under the program we are making to diagnose our children and not to miss any such child because he has either early symptoms, or the classical diagnostic methods are missing pediatric TB, or, so the effort has to be totally complete from not only from actually looking for TB, whether using screening methods, but also diagnostic techniques. All that is available under the arena. The program has ensured that the latest diagnostic modalities are available, but things like whether at the periphery the right sample can be collected, a gastric aspirate can be collected, or an induced sputum can be collected, or if there's an extrapulmonary presentation, the extrapulmonary sample can be collected, will have to be ensured by our teams at the periphery. So I would conclude by saying that pediatric TB is an area where special effort is needed, just like a child would need a special effort for taking care. But then missing these children, the missing TB in children will be a big fallacy on our part, total disservice on our part if we are missing a child with TB. So today's case, I think, is going to actually bring out how delayed diagnosis actually led to dissemination of TB and a presentation which they will elaborate on. So with these words, Dr. Sangeeta, thank you to you and your team and your institute for continuing this effort. And I'm sure everybody who attends today will have several learnings they will take home. So maybe I can come back later with more points, but thank you for now. Please initiate.
Yeah, thank you, Dr. Urvashi. I mean, all the points which have been raised by you, they're very pertinent because diagnosis of pediatric tuberculosis can sometimes be, the symptoms can be vague, and that leads on to dissemination if the body resistance is poor. So over to Dhulika now. Dhulika.
So without any further delay, we would now like to start today's session. Today's presenting team is Department of Pediatrics, AIIMS Bhopal, led by Dr. Ambar Kumar, Additional Professor, Department of Pediatrics. The case presenter is Dr. Mohnish Darshan, Resident, Department of Pediatrics. And the national expert for today's session is Dr. Sangeeta Shah. Over to you, Dr. Ambar and Dr. Mohnish, for today's case.
Thank you, ma'am.
Dr. Ambar, your voice is echoing. If you could just check it once.
Shall I start?
Actually, your voice is echoing.
Those, I think it must be government to the device, So you have to keep them in a separate room or you just leave the device out.
Dr. Monish, this is Dr. Shikha Malik. You can come in my room and present it.
Yes. Then we already called. Just one minute. Just 1 minute. Yeah, is it okay? Is this okay? No,
there are two devices. There are two devices together at some place.
Yeah. So you will have to doctor because we can see.
But you can come with Monish in my room and do it because there are there are many devices around your room.
Is this okay, ma'am? No.
No, still there is.
Okay. We'll go there. We have joined with. We have joined from separate device. So, is this okay, ma'am?
Yes, now it is better, I think.
Yeah. No, now it's okay. Okay, we are safe.
Yeah, you can start, Dr. Manish.
Yes.
Is the screen visible?
Ma'am, should we start, ma'am?
Yes, you can start.
Okay.
Dr. Amber, your screen is not visible now. It was visible initially. If there is an issue, we can share it from our side as well.
No, this. Okay, this. No, ma'am.
Yep. Okay. In the meantime, the audience can take up the pre-test questions. The link for the same has been uploaded in the chat box. Dr. Amber, shall we share the screen from our end? The PPT.
No, ma'am. We'll share, ma'am, from here. Just 1 minute, ma'am. Yeah, we are starting, ma'am.
Ma'am, is the screen visible now?
Yes, yes.
Good afternoon, ma'am. This is Dr. Monish Darshan, a junior resident from All India Institute of Medical Science, Bhopal. I would like to thank my guide, Dr. Amber Kumar, addition professor, and my head of the department, Professor Dr. Shrika Malik, ma'am, All India Institute of Medical Science, for this wonderful opportunity to present it in a esteemed platform. So now we'll be going to the case. A 10-year-old female had actually presented with the complaints of fever since last 2 months, with difficulty in walking, followed by inability to use both lower limbs since last 1 month, and on and off headache with vomiting since last 10 days. Initially, the symptoms of fever, we started on day 1 with the duration of 2 months on and off. Initially low grade associated with the evening rise of temperature and sweats, and also associated with chills and rigors, but relieved by medications. Later, at day 30 of illness, the child had complaints of lower limb weakness, which was sudden in onset. Initially started on the left leg, followed by right leg, being asymmetrical. But there was no history of upper limb weakness or truncal weakness, and no distress, and there was no diurnal variation in the weakness. But distinctly, the child had complained that she had a band-like sensation noted over the hip region, which was later followed by complaints of headache, which was also insidious, progressive in nature, intermittent, diffuse distribution, severe in intensity, especially early morning episodes were noted, also associated with vomiting. Also, in the last 10 days before presentation to our institute, child had complaints of constipation. Along with this, the mother had complained that there was documented loss of weight as well as appetite since last 2.5 months. There's no history of seizures, altered sensorium, loss of consciousness, vision loss, difficulty in chewing, difficulty in shrugging shoulders, tongue deviation of articulations, urinary or fecal incontinence, involuntary movements, neck stiffness or neck pain. Also, there's no history of travel, immunization, loose tooth before onset, no history of trauma, tobacco, discharging sinus or TB contact, no history of dog bite, snake bite, rash over eyelids or hands, no history of any food consumption, and no history of any similar illness in or similar febrile illness in siblings or in the neighborhood. Anthropometry-wise, actually the child also, past history, the child had history of tuberculosis in the family. Actually, mother was diagnosed 8 years back as a pulmonary TB, was started on treatment and had a good complaints, during which the child and mother were separated in 2 different homes. So there was no direct contact with the child. She had responded, there was clinical signs of symptoms, and now currently there's no other symptoms in any other family members. Immunization history, she has received all immunization till age. BCG scar is present. Family history, the other sibling has no similar complaints. Socioeconomic history, child belongs to upper middle socioeconomic class according to modified Kupasamy scale. Anthropometry wise, child had a weight of 25 kgs and a height of 84 centimeter, which was between 10 to 50th centile and 50th to 90th centile respectively. But the BMI was found to be low, 12.2 kg per meter square, which indirectly indicates the child is belonging to a category called severe thinness. Vitals was found to be stable. From head to toe examination, there was no neurocutaneous markers. Significant pallor was present. No ictus, no clubbing, no cyanosis, pedal edema or lymphnopathy. Skin, hair, and nails were normal. No neurocutaneous markers, cutaneous markers of tuberculosis. BCG scar was present. Spine was normal. On CNS examination, higher mental functions were child was conscious, oriented to time, place, person. Abstract thinking was normal. Child behaved well dressed. The cranial nerve examination was found to be unremarkable. No deficits were noted in any of the cranial nerves. Motor examination, the bulk was found to be equal and normal on both upper limb and lower limb of bilateral sides. Tone was found to be reduced in bilateral lower limb. Power was found to be 0, indicating plegia, and superficial reflexes were intact. Deep tendon reflexes were absent in the lower limbs but intact in the upper limbs, and plantar was found to be extensor. On sensory examination, pain, temperature, and pressure were intact in both upper limb and lower limb of both sides. But significant loss of posterior column sensations, which is fine touch, vibration, and proprioception, was noted below the hip region, which corresponds to the dermatome L1. Cortical sensations were found to be intact. Apart from that, cerebellar functions were intact in upper limbs but could not be tested due to 0 power in lower limbs. Coordination was intact in upper limbs. No signs of meningeal irritation, no autonomic disturbances, and spine and cranial examination was normal. Other systemic examination, CVS was found to be normal, no murmur. Bilateral air entry was present, no added sounds. Examination of abdomen was unremarkable. Categorization of a CNS diagnosis, the neurological deficit was localized to human paraparesis with spinal shock with bowel involvement. Since the child had presented with the lower limb hypertonia with absent DTRs, but plantars were extensor along with the history of constipation. Hence, human paraparesis with spinal shock with bowel movement was kept. Posterior column involvement was also noted since there was loss of vibration and proprioception below the L1 dermatome with sacral sparing. Anatomical localization, spinal cord corresponding to the L1 segment. Pathology most probably intramedullary lesion with sacral sparing, since the child did not have any other signs and symptoms of extramedullary or intradural extramedullary compression. Etiology most probably since 2 months with acute history of chronic history of fever with loss of sensation of lower limbs and loss of movements of lower limbs. Infective myelitis was kept first, more than demyelination, more than nutrition and ischemia, being unlikely. But in view of headache and vomiting, there was a suspicion of intracranial involvement also. Initial investigations were hemoglobin was 11, TLC was 10,000 with a normal differential count. Platelets were 351,000 with a normal renal function. CRP was found to be mildly elevated, 7.476. CSF was done where protein was found to be 33 and glucose was 60, which was normal. Fluid cell count was revealed 9 lymphomononuclear cells. AFB CBNAT was negative, culture was sterile, and in view of suspicion of LETM, the autoimmune panel was sent, which is avoided. Chest X-ray was done, was found to be normal. In view of intracranial pathology, and since there was a localization of L1 segment with the probable involvement being LETM, transverse myelitis, we got an MRI brain and spine done, which showed multiple subcentimetric T2 hyperintense lesions with peripheral dark rim, T2 trim, in both being extensively distributed with predominance over left frontal lobe, right frontal lobe, and bilateral parietal and temporal lobes. Maximum largest ring enhancing lesion was noted at the left temporal region. The red arrow marks shows the hyperintense lesions, the ring enhancing lesions, and the blue arrow mark shows the perilesional edema, which is significant. Multiple similar morphology discrete ring enhancing lesions were noted in bilateral cerebellar lobes, largest being in the right inferior cerebellar hemisphere, which is 2.3 cross 1.7 centimeter, which is now shown by the arrow. Other two enhancing lesions were also noted in the right corona radiata and left thalamus, with significant perilesional edema. These are the other views which shows the multiple extensively distributed T2 hyperintense rim enhancing lesions. MRI spine revealed a T2 hyperintense lesion with at the level of D11 and L1 vertebral level with cord expansion at this curve, which is depicted by the red arrow in the right side image. With the extensive cord edema noted at least 13 centimeter from the D7 till L1 vertebrae. We had got a CCT thorax abdomen done, which had revealed a normal lung parenchymal architecture, but surprisingly also revealed a ninth right side and left side rib osteomyelitis, which is now either depicted in the red arrow. That's a restriction of the bone rib along with perilesional abscess bilaterally. So the communicating abscess was drained and was sent for microbiological investigation, which revealed positivity for TB. MTB was positive with no rifampicin resistance. Later, we got a screening echo done, which revealed a significant size of mass in the left atrium arising from the left free wall, crossing the mitral wall. Most probably our differentials was vegetations, clot, and atrial myxoma. But since there was no contrast uptake in the CT, so it rules out atrial myxoma because atrial myxoma is a well-vascularized tissue tumor. The probability was clot versus vegetations. But since the child had a chronic period of fever with extensive disseminated tubercular involvement, the possibility of vegetation was overrode. And later we were thinking of follow-upping the child, and if there's a resolution despite any antifibrinolytic therapy, then it might go favor with vegetations. This is the video of the echo. No, it's not playing. Found to be negative. So there was extensive disseminated tuberculosis. We were working for the child for underlying immunodeficiencies. Secondary immunodeficiencies like HIV was ruled out. Primary immunoglobulin levels were found to be normal for the age. Lymphocyte subset analysis was avoided. After microbiological confirmation, child started on ATT along with low-dose systemic steroids. After 10 days of initiation of ATT along with steroids, there was an improvement in the power volumes, which is in this table, where 3/5 right knee joint and 2/5 knee joint, along with a 2/5 in bilateral. Appearance of flexus in the bilateral lower limb DTRs, and there was also reappearance of the intact sensations, posterior column sensation, which was initially absent before the initiation of ATT and steroids, which means there is an improvement in the clinical picture. So now we will be discussing about a short note on TB endocarditis. TB usually kills people
Just
about
a second, I will
4,000.
just interrupt you here, Dr. Monish. So we'll take up if audience has any questions with regard to the case, we can discuss them here. And I suppose you're coming.
Yes.
Okay.
Yes,
Madam, I'll like to add on something. Monish, did you tell about the dermatological lesions in this child? So what I recollect, we had a case discussion in this child, and this child also presented with 10 to 12 lesions over the palm soles, which was diagnosed as varicose outside, but it was very typical that all the mother was insistent throughout. The lesions were 8 to 10 in both soles and the limbs of and the palms of the hand, which was also having a pus-like collection. So I believe this is also tubercular dermatological manifestation where it is known that it might cause tubercular verrucae. And this was one of it because the numbers after that, all of them appeared suddenly. Maybe it could have been the dermatological manifestation, or it could have been the vegetations which were there in the heart, which got dispersed at the same time, because almost all the lesions appeared at the same time in both the soles and the palms, and also in the near the medial malleolus of the left lower limb. So this is also probably, I think it has been missed, but this was also one of the presentation where the mother kept on saying that these were the lesions for which she visited 2-3 hospitals. And that was the concern why she had actually visited a medical college and so many private hospitals, wherein they always diagnosed it as varicose. And they also gave her salicylic acid a local application. And of course, the lesion looked just like a corn which has been healed with tip, and because of the application of the salicylic acid and the lactic acid. So that was also one of the manifestations in this child, which I would like to add on, because it was very rare for me also after 30 years of my experience to see verrucae, which are so typical and which could explain maybe that it could have been a tubercular vegetation, or there was a hematogenous spread or a dermatological manifestation of TB. And why this child I am correlating is because it had such a subtle, because her nutrition, she had almost lost 8 kgs of weight in the past 15 days before admission. So that was one thing which was very classical in this child. And the other was that she did not had any seizure and anything in spite of so many lesions in the brain, though she also had perilesional edema. So that is also very typical, where it was so gradual, maybe that her immunity was very good, why she did not manifest seizures, though she had headache with vomiting just for a day or two, which got subsided after taking medication. So this is one more thing which I would like to add for the case. Dr. Monish, you can continue.
I just have a question. I mean, like to get the echo because the child had no, symptoms related to CVS or any syncope or.
Yes, ma'am. Yes, ma'am. The echo was done because the child has some rib osteomyelitis. So the echo was done for the screening purpose and to look for any constructive evidence of constructive pericarditis. But there was no evidence clinically also or not echo wise also. But we found incidental diagnosed vegetation in the LA. And the challenging point in this case was when we found the granulomas all over the brain, then our differentials were NCC versus tuberculoma. At that point of time, we are not aware of the AFB positive from the rib side. Actually, then these are the challenging point. The aim of the NTP is to document TB anywhere in the body and try to document AFB microbiological confirmation from anywhere. Like in this case, GA for CBNAT was negative. The sample from the CSF was negative for CBNAT, but we found TB rib osteomyelitis, and the sample from the osteomyelitis side came positive for CBNAT, and also the rifampicin sensitivity was also documented. So this was the turning point, and that helps in making the diagnosis of disseminated TB and with sensitive TB. So there is the recent NTP guidelines says upfront we have to consider all cases as resistant TB, and we try to document that this case is sensitive, then only we should start ATT. So this was the challenge in this case. Basically, in case of NCC and tuberculoma, the differentiative points are like in tuberculoma, the size is almost always more than 2 centimeter. Like in our case, in cerebellar lesion size was more than 2 centimeter. There was no midline shift. And in case of NCC, there is some hyper intense lesion in the center. That was not there in this case. And if we see the relaxation time, T2 relaxation time in case of MRI, that is less in tuberculosis, but more in NCC because of hyperintense lesion in the core. Similarly, we can do the MRS also, magnetic resonance spectroscopy, to look for lipid and lactate peak. Lipid peak is in case of tuberculoma, that is because of presence of cell wall, and lactate peak is because there is anaerobic glycolysis in case of tuberculosis bacteria that will produce the lactate peak. So lipid and lactate peak we can document. So these two were the challenge in this case. First, to confirm whether it's tuberculoma versus NCC, and then after once the diagnosis is confirmed, then another challenge was when to treat is as IV methylprednisolone pulse therapy for transverse myelitis, or we should go with normal dose of dexamethasone with ATT for in this case. So we decided to go with normal dose of dexamethasone or normal dose of prednisolone with ATT because there was risk of flare of tuberculosis in this case, because this case was disseminated to almost all over the all organs of the body. And this case also tell us about that TB can involve any system of the body. So this is the classical case in which we can see the TB can involve any part of the body.
So what is ECG problem?
Dr.
Yeah,
Sangeeta,
any other question?
ECG.
Yeah, Dr. Sangeeta Ashwini here.
Yeah,
Good afternoon.
Good afternoon. Just
It's a nice.
ECG normal, and what is the
ECG was normal.
video is off.
ECG was normal.
ECG was normal, blood sugar also within normal.
HbA1c.
Negative.
Yes, ma'am. Yes, ma'am. RBS and HbA1c was found to be within normal.
You know, whenever you disseminated disease, so one should always, the message to be learned from the examination in this case is that always examine the child as a whole, because maybe the easily accessible sites, like we say, always go ahead with the neck examination to see for cervical lymph nodes. And as in your case, you could pick up the organism from that local draining axis. So osteomyelitis, if there is, always send samples. So these are the important learning points in this case. And as you said rightly,
Why I'm not getting video?
so there is
My video is stopped. Please continue.
always, in this case, whenever there is CNS involvement, along with the, this spinal cord, there was no backache, because that is important. There could be associated involvement of the vertebra. So, like ask the child to bend forward, and so, these are very simple tests which can tell about the vertebral involvement and root pains, because there were absence of root pains, so that means there was no extramedullary compression, so the pathology was inside the spinal cord, that is intramedullary. So I think, are there any other questions?
Sangeeta, just a brief comment.
Yes, please. Yes.
This is an interesting case to learn something new every time.
Yes.
So with low grade fever, you are not going to have chills and rigors. So one has to be clear, and we should not be emphasizing every time to look into tuberculosis, low grade evening rise fever. That is obsolete now. And one more thing which I would like to add on is that when we are dealing with NCC, generally it's an incidental finding. Now we can see multiple, but these patients will never have fever for 2-3 months or so long as this patient had fever in the beginning.
Yes, sir. Yes, sir.
So after we are getting this CT and MRI, NCC is just an incidental finding that patient present with either with a generalized seizure-like activity or a partial seizure, and then we subject them for neuroimaging. So I don't think in this situation we have to think of NCC as one of the differential, also just keeping only the imaging picture in front of this, because we have to take into consideration the other presentation also. Multiple system involvement in NCC. How are you going to explain the involvement of cardiovascular system? How are you going to involvement of ribs and so on and so forth? So I think the diagnosis is straightforward.
Yeah, right, sir.
Are there any other questions?
Any other questions from the audience? I think we can go ahead, Dr. Monish.
Now we'll be discussing a short note on TB endocarditis. Cardiac TB usually kills nearly 4,700 people daily, hence posing highest burden in the developing countries. Cardiac involvement may be associated with the pericardial involvement, myocardial involvement, and valvular involvement. Mostly TB involves pericardium most commonly, followed by myocardium, followed by aortitis, followed by a very rare presentation as endocarditis. So there are very rare descriptions of valvular specific signs. Most patients present with constitutional symptoms, of which the most common symptom is fever, followed by weight loss and lethargy. And very rarely, the child presents with other cardiovascular complaints like palpitation or breathlessness. There might be other frequent symptoms like unexplained weight loss and lethargy. So diagnosis from clinical features alone is difficult, hence there's an overlap with miliary TB because of non-specific symptoms. Rare presentations also occur with other cardiac diseases unless concurrently involved. So there, in case of valvular dysfunction and tubercular endocarditis, it presents with dyspnea and reduced exercise. In diagnostic issues in TB, 16% detection rate is noted for sputum positive TB. But the issue is the TB may occur sometimes without pulmonary TB. Hence, the specificity of sputum analysis is very low for diagnosis of TB. And also, there are no studies yet on the diagnostic basis of valvular disease in pulmonary TB. Miliary TB is more commonly strongly linked to endocarditis, in which sputum analysis can be a added advantage. Hence, since miliary TB is more strongly linked to endocarditis, it helps us to support the hypothesis that miliary TB helps to involve the endocardial part of the heart by the hematogenous spread. AFB staining and TB cultures have improved diagnostic accuracy, but no single test has 100% predictive value. For example, Zane-Nielsen test has a sensitivity of 50 to 80% and culture of 98%. But the issue is it is swimming. Positive bacil not always isolated. Hence, now there are upcoming ways of diagnosis of TB, like liquid culture being the fast helps in noticing a fast growth and a high sensitivity compared to the solid media. But the literature on TB, TB endocarditis often lacks details on the culture media used. Coming to molecular diagnosis, polymerase chain reaction helps in the early diagnosis of tubercular pathology, but it is successfully used in tubercular myocarditis, and there is no published reports of usage of PCR in the diagnostic purpose of TB endocarditis. These are the number of reports currently in the literature, which helps us to increase our knowledge on TB endocarditis, but everything is based on adult cases. Pediatric cases are very sparse in literature. Echocardiography is the first line imaging for suspected infective endocarditis and has provided crucial diagnostic information since 1980. There are two types of echocardiography. One is transthoracic and one is transesophageal. Transthoracic is invasive, but the issue is it has lower resolution and it has its limitations, like it can, as the resolution is or much lower when done in a patient who is obese or is having underlying respiratory pathology. Hence, transesophageal echo is more favor for finding infective endocarditis, especially obese and respiratory disease involvement. Hence, because it has superior spatial resolution, but the issue is it is more invasive. In culture positive valves, the transthoracic echocardiography often misses vegetations despite good functional assessment. This is due to the small lesion size which are undetectable by the transthoracic echocardiography. Hence, there is a upend of the transesophageal echocardiography compared to the transthoracic echocardiography. But the issue is there's no published data on transesophageal echocardiography's use in TB endocarditis, and no comparative study between the higher efficacy or the lower efficacy of transthoracic versus transesophageal echocardiography for diagnostic accuracy in TB endocarditis. The criteria and the considerations in TB endocarditis involves the echo findings, which are suggestive but neither sensitive nor specific. Definitive diagnosis is based on clinical assessment, blood tests, imaging, and tissue cultures. A high index of suspicion has to be kept in immunosuppressed patients, miliary TB, and those patients who present with prominent constitutional symptoms. It also helps us to rule out other common causes of infective endocarditis. Diagnosis is confirmed in a case of suspected TB endocarditis if there are positive echocardiographic vegetations and positive TB cultures with the clinical signs of endocarditis. These positive TB cultures can be either from the valvular vegetations, or if there is evidence of positivity in any culture from any other site in the body with towards TB, then we can consider it to be a TB endocardial involvement. The management is pre-antibiotic era. It was completely supportive. Usually, the diagnosis of TB endocarditis in the pre-antibiotic era was mainly based upon the autopsy reports, which showed granulation and AFB staining in the valve in the autopsy. But now, since there is a good medical diagnostic as well as management protocols, now we can easily diagnose them based on clinical echocardiographic and culture evidence. Now, the current evidence, there are no large randomized control trials on the management, follow-up, or pharmacology of management of TB endocarditis. Treatment is usually extrapolated from the guidelines of pulmonary and miliary TB regimens. It assumes standard TB chemotherapy is effective for TB endocarditis. Surgical valve replacement for damaged valves, aggressive anti-TB chemotherapy for disease eradication is mandatory. TB endocarditis per se is not infectious unless there is a concurrent pulmonary involvement. Positive blood cultures and tissue cultures, if positive, then we have to initiate anti-TB treatment immediately. The main challenge is timely diagnosis. Despite advances in diagnostic and management imaging, treatment differs from conventional infective endocarditis. Like TB endocarditis, there is a prolonged ATT therapy, but in case of bacterial endocarditis, we have to go ahead with IV antibiotics like penicillin and amigdalogasides. Clinicians often delay anti-TB chemotherapy until diagnosis is confirmed and highly suspected. Patients often present without prior anti-TB therapy, and hence the delays in diagnosis leads to progression of the disease towards the advanced stage. Our aim is to reduce this delay, which is reducing the door to treatment time. Hence, it can help us to improve the outcomes in the management of TB endocarditis. These diagnostic delays are also worsened by transthoracic echocardiography limitations. Like as previously discussed, it can miss small vegetations. Future directions are towards wider use of transesophageal echocardiography. Hence, we can not miss these small vegetations and early diagnosis and treatment. Hence, delaying the progression of the or worsening of the disease per se. So, treatment is basically 2 months of HRZD and 4 months of HRE. And the gaps in knowledge are no long-term recurrence or prognosis data on TB endocarditis in both adult and pediatric population. And there are no reports of multi-drug or XDR TB in TB endocarditis at present. So the take-home points are TB endocarditis is a rare but serious manifestation of TB. We need to have a high index of suspicion in every case. Often it presents with constitutional symptoms. Cardiac symptoms might be obscure or be absent. Miliary TB are more strongly linked to TB endocarditis than pulmonary TB. Hence, it supports the hematogenous spread of pathology. Diagnosis requires multimodal approach, which is clinical microbiological imaging and histopathology. Echocardiography, whether it is transthoracic or transesophageal, is essential, but transthoracic can miss small vegetations. No signal diagnostic test is definitive. Positive valve culture with the echo findings are key. Management is the same, anti-ATT with surgical valve replacement if needed. Early diagnosis and reduced door-to-time treatment improves outcome, and long-term prognosis and recurrence data are lacking, and also data on MDR, XDR, TB are also lacking in current era.
So the take-home message is like all the infective endocarditis is not always bacterial, And normally used to consider bacterial as a first cause of infective endocarditis, second as fungal. But the TB endocarditis and TB vegetation is also a possibility that has to be taken care of once we are dealing with infective endocarditis cases. This is all from our end, ma'am. Any questions from audience?
Yeah, actually, I have two questions to ask to Dr. Amber. First is, what was the treatment that the child received outside? Was there any attempt made to diagnose TB in this patient when, because he has presented to you when symptoms were there for almost 2 months, the fever was there. And the second thing I want to ask you is, you have mentioned that there was improvement in the neurological examination after you started ADT along with steroids. So what was the time period after which you noticed this improvement?
Yes, ma'am. The patient outside, the patient has not received any ATT, and there was no effort to to diagnose this case as a possibility of TB. And they have received some normal antibiotics only. And after developing the neurological signs, they have referred back to AIMS. And once they have come here, and once we diagnose this as case of TB tuberculoma with transverse myelitis, and also fortunately we also could isolate the TB also from CBNet from the rib side, and then we started ATT under cover of 2 mg per kg of prednisolone, the normal dose, or we can start Dexa also, the normal dose like 0.15 mg per kg per dose 6 hourly. So we have started oral prednisolone 2 mg per kg per day. And after 2 weeks, these findings were after 2 weeks of ATT with steroid. The significant improvement in the neurological function, power, and the everything that has improved significantly within 2 weeks of ATT plus steroid. Probably steroid has more effect in early period, but the long term, the ATT is a mainstay of treatment in these cases.
So you were able to identify it within 2 weeks?
Yes, ma'am. No, within 1 week. Within 1 week.
Okay.
Within 1 week, we could isolate the TB. Within 1 week of admission.
Dr. Amber, I have one question regarding, initially the child is have also vomiting actually and had so any osmotic just like a mannitol or 3% NaCl also given to this child, or
no, the vomiting that yes, sir. The vomiting was the cause. That's why we performed MRI brain also along with the spine. And the vomiting was not associated with vomiting was not projectile, and neither it was associated with any bradycardia or hypertension. So we were not thinking of any raised ICT at that point of time. And after once we diagnose on MRI that the child has tuberculoma with edema, significant edema around the lesion. So probably the child may have some raised ICP feature, but we have not started any menthol at any point of time. Probably steroid was the enough for the management point of view at that point of time.
Any culture,
Sangeeta.
Yes, sir.
MGT culture till now there is no there is no growth from the rib side which we have sent, and the CBNet from the sputum, gastric aspirate, and from the CSF both were negative.
In the pus sample which was found positive, any culture was sent?
Yes, a culture was sent, sir. We are routinely sending for CBNet, line probe assay, and MGIT, all the three. Routinely we are sending. So till now there is no growth in the MGIT culture.
Okay, Dr. Kamal also want to know, okay, is there any ultrasonography abdomen was done this patient or not? Because
yes, sir. Ultrasound abdomen was done, but there was no other marker of abdominal involvement like any lymphadenopathy or ileocecal involvement. There was this was not there.
And what are the CCT chest findings? Is there any normal parenchymal or parenchymal lesions are also in the
CCT lung parenchyma was completely normal, sir. X-ray also and CT also, except the rib osteomyelitis. That's all.
So why are we labeling it as miliary? If suppose the X-ray is normal, the CT
we are not labeling as miliary. We are not labeling as miliary, sir. Lung was completely normal in this case. This was a theoretical discussion from literature. We have documented this is common in miliary. That's why.
And your radiology, did it show any compression of the cord?
No, there was no compression on the cord, sir. It was just enhancement with the cord.
Because swelling, that is the reason I explained that there were no root pains. Normally, if there is any cord compression, the first symptom which comes is severe pain. So this child did not have any pain. Even I think you must have done the forward bending test.
Yes,
It
yes.
is very simple test. They differentiate between a intramedullary or an extramedullary compression. So the cause was intramedullary in this case. My question is,
Madam, the child actually presented with severe pain at the day of presentation in both lower limbs. So much so that the child could not stand, and then it immediately progressed to not able to walk. So there was a complaint that when the child came back from the school, there was a severe pain in both lower limbs, starting more on the right and then on the left. But there was pain, and after 2 to 3 hours or 4 hours, the child was not able to stand. So this severe pain was there.
so
This severe pain actually explains the posterior involvement, posterior sensation involvement. Hence, we had a possibility of being transverse myelitis because also associated with the paresthesia and the band-like sensation. The child was complaining about the band-like sensation and the pain. Hence, possibility with the lower limb weakness being hypotonia. Hence, we had a differential diagnosis of intramedullary pathology being transverse myelitis.
Mm-hmm. So, is it to see about the vegetations?
Yes, ma'am.
The repeat echo has cardiac echo repeated.
Yes, ma'am. The echo was repeated after 2 weeks. The vegetation size was same. So we are following up this case. We have discharged this patient right now, but we are following up and if the, whether the vegetation is disappearing or whether it's reducing in size or not. So there was no significant reduction, but there was some small reduction in size, like in mm only.
So there is only small reduction in the size of the vegetations. And
Yes,
how many
yes,
months of ATT now?
Child is on 18 mm. It was 18 mm in one dimension. That had reduced to 16 mm, but there was no significant reduction. That may be because of operator issue also, the measurement. So we are not considering it as a significant at right now, but we are following up 2 weekly this child on echocardiography also, whether the vegetation is decreasing in size or disappearing or not.
How many months of ATT has been given till date?
Today is actually day 20 of ATT.
Day 20, yeah.
It's too early, too early. Presentations in this case is that there is no history of any congenital heart disease or rheumatic heart disease. That means there is no defined valves, endocarditis to develop in the absence of miliary tuberculosis. Usually, miliary TB, there is a recent, in this present issue of IJTLD, there is another case report for the same TB endocarditis. So I would also request all our uh, viewers to read that article. That's also another very interesting article. Uh, so any other questions?
One question is, iris increase the vegetation size, the endocarditis.
Immunoconstitution syndrome, sir.
Iris increases the vegetation size.
Iris can, sir, iris is like a system, like if there is pediatric effusion, that can increase in size. If there is tuberculoma, that can increase in size, or it may increase in number also. Similarly, the vegetation also we can predict, but I am not sure because we don't have any literature on iris on TB endocarditis. But that may show increase in size in initial 2 weeks, but later on it will resolve with ATT, probably.
You must have read about the long term, does it leave onto sequel, the TB endocarditis? You must have read about that.
Currently, no literature is saying about long-term sequelae in pediatric population, ma'am. But yes, adults there are literature of valvular dysplasia post ATT.
Okay. And how long you have ATT in this case?
In this case, there was no significant regurgitation in the mitral valve or stenosis. So the valve was almost absolutely normal. So that's why we are just follow-up echo is planned for this child. And
No,
hopefully,
ATT.
Yes, ma'am.
Duration of ATT.
A duration of ATT in this case, we are planning for 1 year actually, because there is CNS involvement, spine involvement, bone involvement. So based on these, we are planning for 1 year. But normally the duration is 6 to 9 months. 6 to 9 months.
That is another very important message. Just TB endocarditis, the time duration remains 6 months, but because there is CNS involvement, the duration would be 1 year.
Yeah, yes, ma'am. Yes, ma'am. That's right.
So there is one question also, okay, when we should seek the opinion of neurosurgeon in the case of this case basically, or in the neuro TB, when we have to send the child for the neurosurgery opinion.
If there is development of hydrocephalus or worsening neurological function, then we can seek opinion of neurosurgeon. But in this case, there is no development of hydrocephalus, and these neurological symptoms were also improving, and there is no paraplegia. Even the paraparesis were improving. So that's why we have not sought the opinion of neurosurgeon. But in any case of worsening of paraplegia and development of hydrocephalus, we should seek opinion of neurosurgeon.
Dr. Ashok, you had a question. Sir? Dr. Ashok?
Yes, madam.
Yeah, I think I heard your voice. Wanted to ask some question.
Yes, yeah, I my question was in extension to Sriha questions. So that was answered by the team, but I know what was the level of facility from where the case was referred to AIMS Bhopal. What was the level? Because we have to tap those facility, we have to make the capacity, do capacity building of all those facility, because they should have suspected something.
Yeah, yes, sir. The patient was referred by private practitioner to here at our center, and
previously was taken
okay.
treatment in a nearby government.
It were not government facility. It were not government facility.
No, probably not. No. There was no government facility.
Okay. So that was my question. So in extension to Surekha's question.
Sir, I will like to interrupt. I'm so sorry. But the first place where the patient visited was a medical college for the dermatological manifestation. So the patient visited twice the dermatology at GMC, Gandhi Medical College, Bhopal, where the child was diagnosed as varicose and was given treatment only in terms of local application of an antibiotic, a painkiller, and an antibiotic. Since this did not get, the patient did not get any relief for 20 days or 25 days, they visited a local practitioner who gave some application for the varicose or the child was having. And in view of the high grade fever, then the patient got admitted just for overnight in a hospital and then was referred to AIMS Bhopal. So the patient has been going on for the past 2 months, wherein the problem started with a dermatological manifestation. So this case is very, very tricky because not always this is how the case evolves. And since in between intermittent, there was fever, there was headache, there was vomiting, which did not last for long. And therefore, this constitutional symptoms of, a raised ICT or severe headache, it could not be picked up. It was only for 1 or 2 days where painkiller was given, 1 or 2 days antiemetic was given, and the patient became all right. So these all space occupying lesions with a perilesional edema, though they had their own inflammatory process, but could not be picked up because there was no raised ICT in that case. It was vomiting where the patient and the physician also mistook it as a viral fever, headache, vomiting. Then the constipation of one very striking thing in this case is a constipation for 8 to 10 days. The patient did not pass stool for 10 days. And then, of course, the mother attributed and the physician said that since the child is not eating anything and therefore there is constipation. It may be one of those manifestations when the child had severe pain in the both lower limbs, the constipation. I mean, when you look at it retrospectively, you understand the evolution of the disease. But for anyone who is not thoroughly managing the child or monitoring the child or not seeing the child on every follow-up, it is very difficult and very tricky in this case to pick it up as a case of tuberculosis because it was just starting with a dermatological manifestation.
I think it's a very interesting case.
Very
and we have a lot of lessons which we have learned I mean, as I've said, no miliary involvement, no. The valves were absolutely normal, no history of any serious. And in fact, there was no history of any, except for headache, there was no history which was peculiar, no seizures with such multiple tuberculomas around. So, a very interesting case. I must compliment Team AIMS Bhopal.
And madam, even for the osteomyelitis of the rib, there was no such inflammation on the skin.
Yeah, yeah,
It
yeah.
was only regular, when Monish was examining the child, the patient made a ah, and then they said, "Is there pain?" And then you started palpating. So
Yeah.
there was no such that the skin is having any edema or swelling or redness. It was just an osteomyelitis, which because of the pressure, the child complained of pain. So that is how it got picked up, that it was having the organism ultimately got picked up from the site from where it was in the rib. So again, we were not able to grow anything on cultures. No sign of any lung involvement. But osteomyelitis was there. So chronicity is definitely there.
Mhm. Very interesting case. Any other questions?
And one more thing, there was no history of contact because the mother had taken ATT 8 years back.
Yeah.
Further probing, how could there be any? I mean, you always ask, where is the contact? So there was no contact in the family. She said the child never visits any place. The child has always been staying with her. She goes to the school, and then we asked, then after school, what? Then she says the child goes to the madrasa for an hour for studying. So that is also one of the factors from where, we do see cases coming up from places where we see that there may be some infection caught at that place. So
Yes.
that was one only history where the contact could have, maybe possibility of having a contact at that place.
So, any other questions? I think
So we had an extremely fruitful discussion today, and before we close in, I would like to invite Dr. Ashok Bhardwaj, Chairman NTA, for his closing remarks.
So thank you, madam. Thank you, Surekha ji. Thank you, Sangeeta, for giving me a chance. So I must compliment Dr. Shikha Malik and her team. So what she revealed that the case was missed for dermatological tuberculosis at Gandhi Medical College, Bhopal. So this is a cause of concern for me also. So otherwise, AIMS Bhopal is an apex institution in the state. So I visited this institution on 9th of June this year, and for me, it is only NTEP. So and the functioning, the NTEP in AIMS Bhopal were excellent. So, but one cause for concern for me is that the referral from General OPD of medical colleges in Madhya Pradesh is less than 1%. People are not referring the cases, the clinician are not referring the cases from their outdoor for presumptive TB examination. So otherwise, it should be more than 10%. In a tertiary level institution, the presumption should be more than 10%. But in Bhopal, in whole of Madhya Pradesh, it is less than 1%. And regarding pediatric tuberculosis, the proportion of pediatric TB in Madhya Pradesh, as was presented in a zonal meeting on 11th of June, the same month, so it was about 2%. So I think the majority of pediatric cases they are also missed. So I will request, madam, that you take this responsibility to train the pediatrician of the state. I will request the state TV officer to prepare the batches so that they may come to AIMS Bhopal also, so that these are trained in pediatric tuberculosis. So this is my concern. So Madhya Pradesh is a good state doing remarkably in NTP, but still more has to be done. So I will request Madam Malik to please take this responsibility. We a center of excellence for whole of Madhya Pradesh. So it was an excellent, interesting case. So I gained knowledge about that. I had seen the cases of in adult of endocarditis, the TB endocarditis in Himachal also, but pediatric, I heard for the first time. So thank you very much, madam. Congratulations to your team for presenting an excellent case, an interesting case. So thank you very much.
Sir, and I would request from this forum that medical colleges should join in, because these sessions are proven so useful. They're adding to our knowledge, and we are here to learn from each other. I mean, I would request Dr. Shikha Malik to, share the link with all the pediatricians of the medical colleges in Madhya Pradesh, so that they also join in, and we have more, and more, because we need to increase our knowledge base. I mean, from this case, even we have learned a lot, that this involvement can occur without any symptoms, no symptoms suggestive of serious involvement, and no CNS symptoms except for headache. And in a normal child who does not have HIV, blood sugar is normal, there is no miliary TB, normal valves, and still, the child ended up in disseminated involvement. So with these words, I think now we end the session, Dr. Durika.
Just one comment, ma'am, before we finish, because this is very odd to have such deep, unusual sites, and the usual ones are completely missing: lung normal, abdomen normal, everything missing. So maybe a workup of something like MSMD or something which can explain this unusual presentation of TB can be.
Yeah, I think they've already sent some further investigations, which the reports are awaited.
Yes, ma'am. We have sent the PID workup to NIH, and we are awaiting the results.
Yeah.
So with this, I will request the audience to please attempt the post-test questionnaire as well. The link for the same has been shared in the chat box. And with this, we come to the end of the 16th Pediatric TB Eco Clinic. The next Eco Clinic is scheduled for 3rd Tuesday of September, and the presenting team is by JJ Medical College of Mumbai. So we wish to see you all in the next TB Eco Clinic on 3rd Tuesday of September.
And I also request from this forum, if you have any feedback, we want constructive criticism, because only then we can grow as a team together. Because you are also our pillars of strength. So please provide us with feedback. We are directly accessible on emails. I think our email is there. Then we have also this group. So what you want to see, what has been missing, because I mean that is how we learn from each other in a more prospective manner. So with these words,
if you will allow, I'm so sorry for interrupting. I thought it will end. Madam, this is the need of the hour. Your sessions are so brilliant that every time I join, I learn something.
Yeah, even I
more times I have could join because there are certain other commitments. But otherwise, madam, if it is really put that it should be somewhere mandatory to join this site by ultimately it is a PG teaching program. So if the medical colleges can also join, now there is no such problem of any signals. I mean, can it be done through the government or through the colleges to have it mandatorily, because it is one of the most important things. Now we are coming again back to pediatric tuberculosis in a big way, and it is really going to help. And all these cases, they give you a lot of insight for management of diseases which are not so evident. I mean, for tuberculosis, not coming with the normal signs and symptoms. It gives you a cue that maybe, yes, it could be tuberculosis. Sometimes it is very difficult to see for a clinical confirmation, but microbiological confirmation, but clinically you have a very, very strong suspicion it could be tuberculosis. So it's a great, madam, it's an academic treat for, at least for me, that I look forward to. And it has been a great association, and with the comments of everyone. And Dr. Ashok, thank you so much for the kind words. All credit goes to Amber Monish for presenting it. I just, barged in, that is what I have done. And only thing is, sir, that we would be happy to have the Center of Excellence and to do the training and whatever that you require. If that be so, we can have a, we can go ahead with this. So thank you so much, ma'am.
So thank you Again, I mean, a very fruitful, interesting session. So I think we'll say bye now and meet you next month. Thank you all.
Thank you.
Thank you.
We keep it running for 2 more minutes so that the audience can attempt the post-test questionnaire.